Disorder and reactive attention disorder. Oppositional defiant disorder is a type of behavior disorder that is mostly diagnosed in childhood. Children with ODD are uncooperative, defiant, and hostile towards parents, teachers, and other authority figures. These behaviors often disrupt the child's normal daily functioning, including relationships and activities within the family and at school. While AD is a condition or emotional dysfunction, it's a condition of emotional dysfunction in which a child does not form a secure, healthy, or emotional bond with their primary caretakers. Children with AD have trouble managing their emotions and rarely show signs of discomfort because they may seem fearful that they may seem fearful of their caretakers. They are often irritable, sad, and report feeling unsafe and alone. According to the DSM-5, order for a child to be diagnosed with ODD, the child must have at least four symptoms of angry, irritable mood, argumentative, defiant behaviors, or vindictive to be diagnosed. So here is a list of some common signs and symptoms of ODD and RAD. So symptoms can be mild, moderate, or severe. So for symptoms to be mild, it means that the symptom occurs only in one setting. So for it to be moderate, it means that it occurs in more than two settings. That is maybe at home or at school. If it's severe, it happens in more than three settings. And here is just a list of some of the common symptoms of RAD and ODD. So a review found that the prevalence of ADD is approximately 3.3% across multiple cultures. Other reports listed a prevalence of 1%, 1 to 16%. It is more common in children who live in poverty and more common in boys than in girls. Census reported 5.22 in 100,000 diagnosed with RAD annually. So the etiology of ADD is not clearly defined. Most suspecting it is caused by a cumulative effect of multiple risk factors that stems from biological, psychological, environmental, as well as social issues. So for RAD, it is always trauma, specifically the severe emotional neglect which is commonly found in institutional settings, such as overcrowded orphanages, foster care, or in homes with mentally or physically ill parents. Symptoms with ODD and RAD often disrupt a child's activities of daily living as well as quality of life.
So occupations that may be impacted are school and work. Their behavior often actually disrupts the child's normal daily functioning, which includes activities within the family and at school. And this may lead to problems at sports, school, and work performance. When it comes to play, their behavior can be stressful in other aspects. And, and they will not want to engage in any activities with them. So, eating. These children actually refuse to follow rules and take directions from their parents. They become aggressive and snatch food and water from the dining table. And this behavior affects the occupations of eating. When it comes to process skills, empathize is one of them. With ODD and RAD, normally display inappropriate affection towards strangers while demonstrating a lack of affection for their primary caregivers. Replies. They tend to have frequent arguments with authority figures and active defiance and refusal to actually comply with adult requests and rules. Expresses emotion. They fail to show unexpected range of emotions when interacting with others, and fail to show emotions of conscience such as remorse, guilt, and regret. Looks. They try to avoid eye contact and physical touch, especially with caregivers. When it comes to regulate, kids with ODD are always show irrelevant and impulsive behaviors that are not part of social interaction.
So, interventions, because ODD is a diagnosis that mainly impacts social interaction skills, we designed our intervention around promoting healthy interactions with peers, emotional regulation, developing new coping skills to manage anger and frustration, and improving rule following. So, the intervention that we created is most appropriate for use in a school setting, but it can also be used in a pediatric clinic that facilitates groups. So, for our intervention, it should take about 30 minutes. And in a small group setting, we're going to have the children discuss situations that they have experienced recently that provoked strong emotions in them. And then they'll talk about how they handled those situations. Then we'll have the children work together to write a skit about one of these difficult or stressful situations and how they could have changed their reaction to create a better outcome. Then we'll have the children act out the skit together and allow them to switch roles as desired. If the time allows at the end of the session, we'll have the children come together again to discuss both the positives and negatives of the new situation that they acted out. So the materials that you'll need will be pencils and paper to allow the children to write their skit, and then any props that the children want to create a realistic scene. This intervention will target several performance areas, so it helps children improve socialization skills and learn to work in teams, helps children get accustomed to possible disagreements with peers. It allows the children to practice mapping out healthy social interactions. It helps children develop healthy coping skills to deal with difficult situations, provides insight into adaptive and maladaptive behaviors and how these behaviors can change the outcomes of different scenarios, and then it helps students to identify triggers to outbursts or triggers to maladaptive behaviors. Interventions for ODD are typically guided by the behavioral frame of reference. So, the behavioral frame of reference uses behavioral modification methods to change behaviors. So, behavioral modification methods can include positive reinforcement, such as praise and rewards. In a school setting, typically teachers use behavioral charts or they give out school dollars that students can redeem for prizes. Repetition of desired behaviors, implementing consequences for maladaptive behaviors, such as taking away recess, giving lunch detention, or taking away a star on a behavioral chart. And then education on healthy versus unhealthy behaviors and how those can affect different situations. Some goals that we decided on for treatment. So our first long-term goal is patient will interact with peers in a positive way to promote healthy social relationships. The short-term goal that goes along with this goal is patient will have one positive interaction with a peer daily over the next 4 weeks. Our second long-term goal, patient will minimize disruptive and maladaptive behavior to promote success in the classroom. And then our short-term goal that goes along with that one is patient will identify and use 3 healthy coping skills 75% of the time when strong emotions arise within 3 months. So we feel that these goals fit into the SMART format and are achievable and realistic for students to work on. So safety during treatment sessions, the biggest safety concern is that children with ODD are more prone to outbursts, and these outbursts can be physically and verbally aggressive in nature. So some steps that we can take to maintain safety during an outburst would be to remove other children from the area and isolate the child having the outburst. Call for backup from other staff or security if possible. Use de-escalation techniques such as therapeutic rapport, giving the child plenty of personal space and allowing them to take a break if needed. And then you can always call 911 for additional support if the situation is escalating and you feel that either the child or other children or you are in harm's way. So working towards discharge, our intervention can be graded by adding new small group members, having group members discuss increasingly difficult or stressful situations, and having the children use their coping skills in the classroom and report back on their effectiveness. Discharge planning should always start as soon as the child enters therapy so that they have a good idea of what goals they are working towards. Some signs that a child might be ready to be discharged from occupational therapy include less frequent outbursts or disruptions. Their grades might be improving. They might be developing more positive peer relationships, and they might have fewer punitive actions taken against the student. And these are our references.